Hello, everyone, and happy Thursday Night Live. We are here with a very special guest tonight, Dr. Harald Hrubos-Strøm. Welcome to the Airway Circle stage. I'm going to go ahead and introduce the speaker, tell you guys about the topic. So, presenting Dr. Harald Hrubos-Strøm, the head of sleep surgery at, oh my goodness, help me with the university name.
Akershus University Hospital.
Akershus University Hospital and an associate professor at the University of Oslo. He leads the hospital's otorhinolaryngology research group and co-leads the sleep, heart, and respiration research group. His work focuses on personalized treatment approaches for obstructive sleep apnea. He has served as a lecturer for the World Sleep Academy and currently holds leadership roles within the Norwegian Society for Sleep Medicine and the National Advisory Board for Sleep Medicine in Norway. Today's topic is novel Nordic sleep surgery. Thank you so much for accepting our invitation to share your incredible knowledge with our Airway Circle community. The stage is yours. You're welcome to share your screen. And we have Sakshi here. Hello, Sakshi.
Thank you. So I'll try to say then share the presentation, and please tell me, Renata, if the presentation mode is not showing.
This is perfect. I can see it.
Okay.
That's it.
So thank you for inviting me, and I think I chose the title Novel Nordic Sleep Surgery because, in fact, Nordic Sleep Surgery disappeared in 2007. So it was a report from Sweden that caused a lot of this debate around sleep surgery in the Nordic countries. And then the whole methodology has evolved for the last 20 years, but we have not been following that train in Nordic countries. But now the pendulum is changing, and I think we are contributing in some very exciting ways. So I'll try to show some slides, and please have questions afterwards if you like.
Would you share with us a little bit about this incredible art that you have on your screen?
Yeah, this incredible art was made by my first PhD student. I was a co-supervisor. She is called Maria Warren. And she made the front page of her PhD thesis. And I really think it reflects how different everybody are when it comes to sleep. And that is, I think, a core theme in my research is to really try to personalize sleep surgery.
I love it. Thank you so much.
You're welcome. And I, of course, have given some lectures for different industrial partners, but none of them should be relevant for this speech. So I think it's important to know that the ENT perspective is slightly different from the pneumology perspective. We have a focus on the nose and also the eustachian tube, which may be influenced by sleep. And we also have this powerful tool with the dice to be able to study exactly how the upper airway collapses. And then I also want to emphasize how much this intrathoracic pressure is changing in patients with sleep apnea, causing a lot of shifts in the dynamic cardiovascular system. So if any of you are interested in this, in particular this in this intrathoracic part, we're just preparing a very exciting publication on this. I think this study by Kasai and co-workers from 2011 is really worth reading. So, but when I started with sleep research, things looked quite different. It was 2005, and people were 20 years younger than today. And what changed the playing field was in 2007, Carl Franklin published this Swedish report, and he concluded actually that No studies meet the present inclusion criteria, show that weight reduction programs, bariatric surgery, drugs, pacemakers, devices for sleep in lateral position, didgeridoo playing, or any other suggested treatment for lifestyle modification for obstructive sleep apnea. But of course, not having any evidence in 2007 does not mean that these approaches doesn't work. So luckily, evidence has changed over the last 20 years. I, in particular, would like to emphasize this study because at Karolinska Institutet in Sweden, the Nobel Prize place, they designed this really nice study showing that actually the UP3 operation had effect on sleep apnea. Later, they followed these patients for many years, and now recently they have also compared the UP3 and normal tonsillectomy, showing quite surprising findings that tonsillectomy seems to be as good as UP3. But why should we treat these patients? We have this very famous data from the Wisconsin sleep trial, showing that the sleep apnea patients, they actually, if they had an AHI of 30, they had less than 70% alive 18 years after being diagnosed with sleep apnea. And this was a working population, actually people going to work, and then 18 years later, 30% were dead. And in particular, if we look at the CPAP part, less than 60% were alive among those who didn't use the CPAP. We also know that dementia is developed partly by sleep apnea. Of course, the neurologists have a hard time to acknowledge that sleep apnea may cause dementia, and they didn't include it in this Lancet report that was published last year. But they conclude in the text that along with duration of sleep, emerging evidence suggests that quality of sleep, specifically sleep apnea, might be associated with dementia. But the problem is that when we try to treat sleep apnea in heart and dementia patients, the pathology has already started. So we have this very famous RICADSA trial from Sweden in 2016 showing absolutely no effect of a CPAP on mortality and cardiovascular events. And we have the SAVE trial also from the same year, testing CPAP on cardiovascular patients, and also the ISAC trial that came out 5 years ago. So the problem is that we need to start this treatment earlier before people develop cardiovascular disorders, and we probably also should focus on symptomatic persons. I think this is maybe my favorite slide. It's from the Swedish guidelines on sleep apnea treatment. And it really reflects the difference in sleep apnea handling since I started this in 2005. Because when I started, it was all about AHI. And we made a severity definition with mild, moderate, and severe, but we didn't really care about the symptoms. But this Swedish guideline emphasizes that in the symptomatic group, we have a moderate to strong evidence to treat all sleep apnea patients with symptoms. While we have a very strong recommendation to treat sleep apnea patients, even the severe ones, only in those below 65 years and with insufficiently controlled comorbidities such as diabetes or hypertension. So this really reflects the shift in sleep apnea treatment today. We have also published a paper together with Sahlgrenska in Gothenburg, focusing on the longitudinal management, because I still believe that CPAP is the best treatment, and we should, I think, try CPAP for most patients, but we should really emphasize what is the outcome that we wish to achieve. And of course, we want to reduce the risk of future cardiovascular events. And then we proposed in this paper to use the SCORE, which is a calculation of risk, And then we wanted to ask the patient, is the risk acceptable or is it unacceptable? And in this x-axis, we wanted to address the symptoms. And of course, it's sleepiness and it's a lot of other symptoms. So we also on this scale wanted to see, is it acceptable symptoms or is it unacceptable? Do you really want to have a treatment? So if they want to have a treatment, we have this toolbox with all the different tools. I thank AI for generating this very nice illustration of exercise, and also for this not that good illustration of a mandibular device. But of course, all these treatments, but the CPAP has variable effects depending on the collapse pattern. So I think I in particular want to draw attention to this study from Denmark in this year, showing that actually less than half of the patients started with CPAP completed the treatment or had any effect. 55% had CPAP failure. So the problem in the ENT perspective is not necessarily how to make the CPAP work, but what to do when the CPAP doesn't work. And that brings us back to what I like to call the peak rate guess. Because the peak rate is a measure that was introduced by Danny Eckert and co-workers in 2014, measuring the critical closing pressure for the upper airway. And what we really try to do in sleep apnea treatment is to open the upper airway. But what happens if you put these straps on the cheek? You pull this chin backwards, and then you have to have a much higher pressure if you use a full face or oral mask. So if you can't use the CPAP, we really have to guess what is the mechanism. And of course, if we believe after a clinical examination that the tongue is sliding backwards, an oral device would be a very good operation. Or if we think that really the upper airway is collapsing in the lateral plane, we should definitely consider to remove some tonsils or do other kind of oral surgery. But I really challenge my doctors in my department to do this guess, to really think what you think is the best, is the probable collapse pattern. And of course, we do have some ways to try to measure this and to do a better guess. I have a postdoc student that did her PhD on computational fluid dynamics. But that is made on a CT that was taken while the patient was awake. And at the last World Sleep Conference, we also saw a lot of presentations on echo or ultrasound of the upper airway. But still, that is also examination obtained during awake. So does it really reflect what is happening during sleep? In my opinion, I think still the best tool we have is the DICE. And we introduced this tool 3 years ago in our hospital. And I'm trying to build a network in the Nordic countries focusing on the calibration of scorers. Because we score at the velum, at the oropharynx, at the tongue base, and the epiglottis. And then we also see, is it no obstruction or is it any kind of obstruction, and what is the pattern? So if we don't calibrate the scores, the inter-rater and intra-rater variability would be so high that it would not be useful. This is the setup that we do in our hospital. Unfortunately, we still have to use the operation theater because of very strict regulations for anesthesia personnel in Norway. But we have so far made 110 DICE. And I think this has really made us think differently on CPAP treatment and all kind of treatment. And also a very popular buzzword in the sleep community is endotyping or endophenotyping. And my favorite paper on this is this paper from 2017, showing the plethora of different tools. And also it illustrates the complexity of using endophenotyping. So still, I think that we do not have one way of endophenotyping that really could predict clinical outcomes. That will still have to be found in the future. But the most popular 4 types of endotypes is by far the Palm scale that was introduced by Danny Eckert and co-workers at Harvard in 2014. And here you find the peak rate that I mentioned previously, but we also have the loop gain, which is the central drive to breathe. And then we have the arousal threshold, which is really very closely related to insomnia. So if you have a very light tendency to wake up, you might even not be diagnosed with sleep apnea because you wake up before the 10-second limit. And then, of course, we also have the muscle strength that is in particular relevant for speech-language pathologists. So that leads us to a concept I call secondary diagnostics. And that is because in some patients, the sleep study is not enough. We need some more tools to find out how to personalize treatment. In our hospital, I have already mentioned the DICE. And of course, we have information from the NOx T3, which is our preferred tool. But also we have the possibility to use data from AirView to look at the personal profiles if we just can get the data from ResMed. And also we have a questionnaire that we have standardized, and we have the possibility to aggregate data to hopefully in the future have secondary diagnostic information based on an automatic tool. And these are the characteristics of some of the DICE examinations that we have done in our hospital for the last couple of years. So for the first 80 DICE patients, we see that the population we have is relatively typical for a sleep apnea patient population with 1/4 female. And also in the Norwegian context, we have a mean BMI somewhere around 30, I think, in our population. So then let's look at how to handle the different types of collapse. So if we start with the complete concentric, in the Nordic countries, we don't have access to Inspire or any of the hypoglossal nervous stimulation devices. The government still are very skeptical on surgical approach to sleep apnea. So I just wanted to show this patient with a complete concentric that I operated with the barbed reposition surgery. And if we then get this link, oh, I just have to close down, sorry. This one. And I think then we can, and now I think, Renata, you must, if the link doesn't show, please tell me.
Oh, it's because we're sharing the presentation. If you open a different link, we can't see it. However, I already have so many questions in my mind right now.
Okay.
Let's see. We may have to unshare and share the screen or the
I can
link
do that.
instantly.
Okay, let's do that. And I'll then share the whole screen. Yeah, so this is a recording of the DICE. And I think from 1:45 approximately, we see a very, first of all, we see it's mostly anterior posterior, the collapse. We also see a very strong lateral part of it. And what we see here is a very strange vibrating part. I unfortunately do not have the sound on this, but we see actually what is called grounding. And that is when we get the snoring sound on the breathing out, not necessarily breathing in. And when I learned about sleep apnea for the first time, I learned that snoring was only happening while inspiring. But this patient really shows that you also have an expiratory problem. So I just wanted to illustrate that, and also the tongue base is really protruding here, really preventing and really making oral device maybe a good treatment option. But let's go back to the presentation, because I really want to use most of my time in one very interesting patient. Also, when we look at the decisions that I made in these 80 first DICE patients, you see that I actually treat as much as half of them, almost, with nose surgery. And that is because we do it to improve PAP adherence. And the literature there, I think, is really strong on opening the nose and converting from a full face mask to a nasal mask. So that is also worth considering, not necessarily doing surgery to cure sleep apnea. And when we look at how the velum collapses, we see that the type of collapse is fairly divided in three pieces, approximately as equal size. And also when we do a SMAC maneuver, which is drawing the jaw forward, we see that we have a slightly different picture than what we see in supine position alone. So that leads us to these two papers that I really would like to recommend if any of you are working with sleep apnea patients. And that is this study from 2016 and this updated systematic review from Eduardo Correa. He's from South America, and he was supervised from Carlos O'Connor Reina in Marbella in Spain. And it really emphasizes the potential role of nasal surgery for PAP adherence. Okay, so let's move on to my main case. And this is a quite young patient. He's 43 years of age. And he came to me in August 2024. We wanted to do a DICE because he struggled to use the CPAP. And he told me that he actually had tried also the mandibular device with no effect, and he had a tonsillectomy in 2013. So that is 11 years before. And after that surgery, he has a very severe arterial bleeding on his left side. 2 days post-operatively, that was he had to be reoperated, and he was really scared to do more surgery. But I convinced him to do a DICE to try to understand what was the problem. So if we look at this DICE, we see that here is his hypopharynx. So remember, he had a tonsillectomy. So we see here that he has enormous remnants of tonsil tissue at the base of tongue. And he also has a very deformed epiglottis, really being sucked into the airway while breathing. And of course, this is almost hard to understand how we can function in daily life with a problem like this. And also here in the velum level, he actually has a lateral collapse of adenoid tissue at the back of the nose. So this patient obviously has a very big problem. And we also, at this time, just after finalizing this DICE, I had planned to do a nasal surgery to straighten up his nasal septum. But then we got a can't ventilate, can't intubate situation, because it was really impossible to intubate through this very deformed epiglottis. So luckily, the anesthesiologist managed the situation by using a larynx mask. forcing these adenoid tissues to the side and being able to ventilate, and we could wake him up safely. And then I have just made a picture of this enormous amount of adenoid tissue in his hypopharynx. And also, this was the problem that they couldn't intubate because it was just impossible for the anesthesiologist to find the hole here. So, of course, we had a problem with a patient that still couldn't use a CPAP, and he still didn't have a mandibular device, and we really didn't know what to do. So I discussed in the sleep apnea friends group, and I got really good advice, and I decided to go further with first doing a septoplasty, and I did that awake because we couldn't intubate him. So I did that 1 year ago, and then he actually managed to use the CPAP and he managed to use the mandibular device simultaneously. But he still had problems at daytime. So when I saw him again in August this year, he was quite satisfied at night, but he was so bothered by these structures at daytime that he wanted the surgery now. So of course, to plan this kind of surgery when we had the can't intubate, can't ventilate situation the previous time was a bit scary. So we had some CTs. We show here the enormous amount of tissue, but note also here, it's something very strange here. When you look at the sleep apnea patient, you usually see a big tongue, but this patient has not a very big tongue, and it's attached to the soft palate here. So I didn't put much attention to that when I looked at the CT pictures the first time. And we planned really thoroughly. We built a support for the camera to be able to go in and look here, but it was very narrow, so we were very anxious to do the surgery. So here is the operation day. It's exactly 1 month previously. We did it on the 13th of November. And here's the patient. We had the tongue lifted up by a suture. And this is my teaching master, Dr. Mitic, that has learned me a lot of sleep surgery. So we had a very surprising finding when we had him in anesthesia, because on the left side, we found the expected adenoid tissue that we could reduce by the defibrillator. But on the right side, we found an enormous adherence between the tongue and the soft palate, what we actually in retrospect could see in the CT already a couple of years ago. So this adherence actually tilted his tongue over to the right and prevented him from opening his mouth. So we decided perioperatively to open this adherence from 2013, and we found really a square centimeter of adherence or scar tissue that we had to open. So this is 10 days postoperatively. You see that I also cut the palatopharyngeus muscle, and I used just one stitch, no barbed suture, just to bind it up. And already here we had 2 fingers of more mobility by the tongue. And also when I looked at him at day 20, he came in because of a small bleeding, and then still it was a lot more room on his right side, and he was really satisfied because he used to have a very voice, feel very sound of all this tissue. But now he had a clear voice, and the tissue was not bothering him anymore. So this really reflects how the surgical approach is important in some selected patients. So when we look at the DICE findings in the oropharynx level, we see that most patients I see, at least in my clinic, is open in the oropharynx level. And sometimes when we do the S-mark maneuver in the oropharynx, that it would be to simulate a mandibular device, actually some are more narrow. So a mandibular device is not a proper treatment for all. If the collapse is lateral, we need to do lateral treatment. And here's the same on the tongue base, that actually here, most are open on the tongue base, but when you do the S-mark, even more open up there. And when we look at the epiglottis, we see more or less the same pattern, that it opens mostly in the S-mark maneuver. So let's move to the final with the anterior posterior collapse. When we do the S-mark maneuver, it almost all the time open here at the epiglottis level. But this patient was actually complaining to me that he couldn't use a CPAP. He said that I'm suffocated. I really put on the mask and it's impossible for me to use it. And of course, when I showed this picture to our nurses, they have completely changed the way of handling this type of patient. Because a couple of years ago, they would say, you just have to try it more. Because if you do enough exercise with the CPAP, you will manage in the end. But I mean, finding this picture of a valve closing over the larynx and the back wall, it's obvious that putting a pressure on this structure will only worsen it. So he will not be able to breathe. And I think that is my most important message, to really try to understand that not all patients can be cured by a CPAP. So he was very satisfied with the mandibular device. And then we also have the adenoid tissue on the tongue base. This patient had a very good help. I think we skipped the dice here because I see that the time is moving. But this patient had a Bimax operation, which is not very common in Norway, at least. I know that some American centers are doing that more. But he had a really good postoperative AHI, but we experienced a lot of postoperative pain in this patient because of this quite big surgery in the age of 51. So here is some papers I recommend on surgical treatment of sleep apnea, and I think it's important to say from a Nordic perspective, where we are not being reimbursed for hypoglossal stimulation. And we also have some studies showing no effect of hypoglossal stimulation. So I think the Nordic community, we are more skeptical of this treatment. Of course, we see studies showing a great effect, but we really lack the good randomized controlled trials on this kind of treatment. So for the lateral collapse, and this is of course mostly relevant for ENT doctors, we have. Oh, sorry. Let's try to take off this laser pointer again. This is a study showing this lateral collapse. So here you see that here the collapse pattern is really in the lateral plane, and it follows the tonsils being sucked together in sleep. And what happens? This is actually when we put this patient in a side position. So these patients actually tend to be worse when they sleep on the side. And most sleep apnea patients, of course, are worse when sleeping in supine position. But with the lateral collapse, they very often have a worse sleep apnea in the side plane. And also what happens if we put the mandibular device on this, it gets more unstable. So I actually try to convince my especially Swedish colleagues that putting a mandibular device on all patients is not a good alternative to sleep apnea, to CPAP. We really need to personalize the treatment. this is just an illustration of a case that was quite good with normal tonsillectomy, and that is also something to consider, in particular if the tonsils are big. I want to end by focusing on a slide from my good friend Carlos O'Connor in Marbella. He showed me this slide on a course in Madrid 2 years ago, and it really is a good way of remembering the muscles back in the pharynx. So here we are looking into the oropharynx from behind. So we see the palatopharyngeus, which is the back pillar of the tonsil, and then palatoglossus, which is the front pillar, and then the uvula, which represents the thumbs in this. So what the Nordic ENT community hasn't learned yet is that the focus for modern sleep surgery is the palatopharyngeus. And when I learned to do a UPPP, I always learned to cut the anterior pillar, not touch the posterior pillar. So I really hope that in the Nordic countries we will use a lot more of modern sleep surgery in the future, and especially we use most of the barbed reposition pharyngoplasty, the BRP, that was developed in Forli in Italy by Dr. Claudio Vicini. We use barbed pharyngoplasty with a V-lock suture of 3.7, and we also are doing some active research now on trying to replace the dice with a dynamic MRI, actually getting the patient to sleep in the MRI machine. And at the very last slide, I would like to just mention that we in our hospital has just finalized the world so far biggest randomized controlled trial on myofunctional therapy. And that was really very interesting experience, because the literature was very positive on this treatment. We are not finalized yet with this preparing the results, but I gave some preliminary results in Singapore at World Sleep, and unfortunately, at least when it comes to intention to treat analysis, we did not find any effect. So when we have the study published, I would love to come back and talk about these findings. But this was my last slide, I think. This is my list of collaborators here. We also have a very good collaboration with Mark Muller and Samantha Muller in LA, and they have coached our speech language pathologist and dentist. This is Unn Tinbod, our speech language pathologist, and this is Diana Dobran Hansen and Xin Feng, and these are the three doing the OMTOSO study. So I thank you very much again for inviting me, and I will now stop sharing, and please ask some questions.
Thank you. That was wonderful. First of all, I cannot wait to see this research. I want to know which exercises they chose, why they chose it, because there's really big research that just came out of Brazil with Dr. Esther Bianchini. You know, in Brazil, the speech pathologists, after they do 500 hours of myofunctional therapy, 2 years to be able to be specialized in it. No other country has that. They also have the opportunity to become sleep board certified by the Sleep Society in Brazil, which also no other country in the world allows speech pathologists or myofunctional therapists to do that. So I know that the research that they have, the exercises they have are very different. There's research by Dr. Bianchini that actually used the camera to see, whenever they were doing the exercises, which muscles are actually you're working on, which ones you open the airway, which one you close the airway. So it's so important for us to have more and more research on this, because half of the time we learn these exercises and we have no idea what's going on in here.
Yeah. I also support strongly the introduction of DICE and the camera into the myofunctional therapy because we had expected to find at least a small finding,
Yeah.
yeah, we have published the protocol, so that was published in August in International Journal of Myofunctional Therapy journal.
Okay, I'll
Yeah.
look it up because
But yeah, I think the Brazilians are world leading in myofunctional therapy. So I also, of course, would like to try to learn more from the Brazilians on this.
yes, they are incredible. I am blessed enough to speak Portuguese, so they are able to teach me, and then I bring it to the
Fala um
US.
pouco também. So,
Oh, that's very good. That's very good. All right, I have some questions.
yeah, of course.
Here we go. Who is the perfect patient for hypoglossal neurostimulation?
That was a tricky one because we don't do hypoglossal nervous stimulation in our country. But I think if I should be lucky enough to have this tool in my toolbox in the future, I think I would focus on those that can't use a mandibular advancement device.
Okay.
Because the advancement is in the same plane. It's for the anterior posterior collapse, but it's quite expensive. And I think if you can solve the problem with a mandibular device, that would be okay. But for some patients, we obviously can't use that.
Perfect. That is part of my second question. What are usually the other options in countries where they don't have access to this hypoglossal neurostimulation?
No, so that is the problem that we have started now after studying these 110 DICE recordings to prepare to do more tongue-based surgery to really remove the adenoid tissue, and there are also developed some methods of actually opening the muscle and reducing some muscle tissue for those who doesn't have adenoid tissue. But I think that are risky procedures. You are close to the lingual artery, and doing so, we're really preparing for the possibility of damaging that artery. Then we really have to have a plan B for doing that.
You kind of answered this one already. Would someone who fails how do you call it, SMARC test?
Yeah, the S-mark maneuver. Yeah.
So would someone who failed that test benefit from mandibular advancement device or the hypoglossal neurostimulation?
No, so I think that is one of my main conclusions that if the S-mark maneuver, just pulling the jaw forward, show that the oropharynx is more unstable, then we should definitely not give a mandibular device, but also not hypoglossal stimulation.
Thank
So I know that some centers are doing, especially with not the Inspire because that requires DICE, but with the other system, they say that we can try no matter what kind of we don't need the DICE. So it would be really interesting to look into their data in the future to see if they still have this data.
I had a patient this week. This is why this is perfect, because I had a patient this week that had a DICE and they did the SMARC and he didn't improve, but they're recommending the hypoglossal nerve stimulation. And I'm like, I don't think that's going to help you. And I see, of course, in my dental mind, I think he needs expansion. I think he needs, more forward growth. So maybe even MMA. Very, very interesting.
Yeah, of course. I also think that also Stanley Liu has this very exciting method in California on opening the sagittal suture and expanding.
Yeah.
So, but still, we need more centers validating that before we can sort of recommend it, I think.
Amazing. Actually, that's so funny because I texted Stanley yesterday.
Yeah.
And I said, can I please ask you a question about this patient that I'm having a hard time understanding what's happening and what his options are?
Yeah.
You mentioned Bimax. Can you explain a little bit what that is for us myofunctional therapists?
Yeah, that is the bimaxillary advance
Okay.
mandibular maxillary advancement surgery. So
MMA.
so that will
Okay.
be a 4-hour surgery by and as an ENT doctor, I don't do that. I just join the skeletal surgeons a couple of times when they do it. And of course, in all patients we have done this, the effect on the AHI is tremendous. It's really good. But the problem is that some patients, they have severe symptoms, especially pain, and some even have still the sleepiness. And then, of course, it doesn't help that much that the AHI is reduced.
That is true. Yes, I do have. That's what I was wondering if it was. And I do see lots of patients for the post-op of
Mhm.
the surgery, and as it can be pretty significant.
Mhm.
Um, Another question, how significant is nasal obstruction or nasal resistance to oropharyngeal collapse? When do you decide to do surgery here before you do surgery here?
I'm very positive to nasal surgery for sleep apnea, even though we know that it doesn't reduce the HI. But I think one of the main problems and one of the main reasons that the government here in Nordic countries banned sleep surgery the way they did 20 years ago was that they also had a lot of reports on poor long-time effects. And I think we have to regard the upper airway as a very dynamic structure.
Mhm.
So if we have a mouth breather developing sleep apnea and we do a surgery, I think that there will be a lot of more suction on these structures than if we have a nasal breather. So my hypothesis, I don't have any data to support this yet, but my hypothesis is really that having a nasal breathing, it creates a stable environment with the bony structures are sort of taking off the pressure. And if you are a mouth breather at night, you will just suck these structures together.
Oh my goodness, I love it. Well, thank you so much for spending this time with us today. You have answered so many of my questions. That was a wonderful presentation. Any last words for our sleep apnea friends community? I did invite them today.
Yeah, and I think I would say once again, thank you very much. And I'm really glad to learn about. I was meeting Mark Muller in Vancouver in 2019, and he challenged me to apply for funding on this. And we were lucky to get this large Sleep Revolution Horizon 2020 funding, and we were able to do this study. So I am, of course, very curious to present it to the global community.
Me too. Well, thank you so much for spending so much time doing that. We would love for more sleep surgeons to be looking into myofunctional therapy and what are we doing wrong? How can we improve it? Which exercises are specific, individualized to a specific type of collapse? I mean, I would love to know that. But
Mhm.
thank you so much. Have a wonderful day, everybody. We'll see you next Thursday. Thank you so much. Bye-bye.
Okay, bye.